Thanks for having me today. So I'm a cardiologist. So why are we talking about primary care physicians? So I think it came up my discussions with Mort. So I represent Kaiser Permanente. We have an integrated healthcare system in Northern California. We have 4.6 million patients. It's like a small country. We have 10,000 doctors and 200 cardiologists. So when we're talking about massive screening, you obviously don't have enough preventive cardiologists to take care of them. And our value-based system is already set up such that our frontline doctors are all primary care physicians. So that's how it came up that if we're going to do this mass screening, then how do we get to the next level and actually get people start treating? So I was going to share some insights. So what is physician burnout? It's the state of emotional and physical exhaustion that so many physicians find themselves in. And it has become really, really crucial since the COVID years. There has been immense burnout across the nation, across our systems. I'm not going to read all the statistics there, but the point is this: that anytime you are planning further screening, multi-organ screening, whatever, then you have to think about what will it mean for the physicians who are already burnt out. Okay. Now, this is so when I say primary care physicians, it could be family medicine trained or internal medicine trained. And in this one, you could see that both family medicine and internal medicine are high up there. And then burnout is actually consistently across all the way. It says cardiology is down there, but I don't believe it. I think we are pretty burned out as well. So, but anyways, I think the non-burnout people got the time to actually fill it up. I'm just joking. All right, so I'm going to stay on time. So what I'm going to use, this is because as a value-based care system, prevention is in our DNA. So I just want to give an example of how we have successfully implemented other programs in the past and how I'm very excited about this future of screening. So as I mentioned, we have 4.6 million members, we call them. And I'm just talking about Northern California, TPMG. We actually have 12 million across all of US, but the biggest presence in California. 4.5 Southern California, 4.6 Northern California. Okay, and then we have done Medicare 5-star consistently for 12 years in a row. So that's the power of sort of value-based care and prevention. Now, it's well known, but I'm just going to share again that we have done leading the nation in hypertension control for a decade. And you could see that how the power of systematic approach. So you could see that we were down here, but once there was system made in place, you could see how we went up within 5 to 10 years. So we have to have a systematic approach to make things happen. Okay, so this is a paper I published, and I looked at, so we have, again, systematic approach to taking care of diabetes patients. And it just shows that with systematic approach, we were able to, compare to USA, much better blood pressure control, better lipid treatment, and better sugar controls. Okay. And this is, I'm very, very, very proud of this analysis. We again looked over a decade. So based on the stuff they've done, so the next question was it meaningful? All the stuff you're doing, is it really meaningful? So it shows that compared to USA, if you're a Kaiser Permanente member, your decline in adult deaths for heart disease was 48%. So it's twice as much decline compared to the rest of the nation. So this is a very powerful data that speaks to prevention, systematic approach. So I just want to sort of share that. Well, thank you. And obviously, this is a whole systematic thing, and that's why I joined Kaiser Permanente. I mean, I was on academic track, and so I'm very proud to work there. So I'm just going to share some of the sort of secret sauce and some of the programs we already have in place. So we have this program called Preventing Heart Disease and Stroke Every Day. So it sort of reminds me of the SHAPE and RESHAPE, good acronyms. And so we have a registry. So anytime any patient gets a heart attack or a stroke, or they are diagnosed in diabetes, since it's a closed system, automatically in our electronic health records, they get marked, and then they get automatically part of this registry. And then we have these treatment protocols in place, and then the team-based approach comes in, where it's not just the primary care doctors, but we have pharmacists, we have NPs, we have PAs, we have a whole system, and they each get their own cohort of patients that they directly sort of work with and try to do that. And then we have obviously quality improvement culture that's in place. There's a feedback, and each one of them are accounted for. Like, hey, you have 2,000 patients on your panel. The blood pressure is not well controlled. What are you, so what are you doing and stuff? And this is just to show that things can be complicated, but you have a system in place. These teams can actually go through this and get it done. So what we are talking about is actually quite straightforward, like CAC and lung nodule and this. So point is that even very complicated things can be done if there's a systematic approach. And then I'm not going to read the whole slide up. I'll stay on time. But so we have dashboards. So if somebody has a high blood pressure, anytime they go to any interaction with their primary care physician, the MA, when they log in, there's an alert that comes up and says, hey, this patient's blood pressure today, even if they're going for like a cataract surgery, comes up. This is an opportunity to control the blood pressure better. So they can message their primary care doctor, or they can message their pharmacist that maybe something is changed. So similar to what our colleague here from VA approached, that if you have these set things, then you don't miss an opportunity to treat these patients and prevent disease. So just coming back to the whole thing, that the ultimate guide to physician burnout, the point is this, that while we are approaching this thing, and we just have to be very cognizant that our colleagues who are actually going to have that conversation with the patients, how do we support them and how we thoughtfully approach that? David mentioned that, in their things, he was thinking 70% will take statins, 50% is very, very good, but our aspiration is actually 70% or 80%. So then we cannot just have another message sent to the PCP, oh my God, now you're responsible for this calcium, now to put the statin, now you have to keep following them. So I think part of it, what I'm thinking is in what Mort wants to do is that make sure that when you have that report, it's attached in a systematic way to some pharmacist or some NP who can actually just go ahead and prescribe the statin right there, and they just inform the PCP that this has been taken care of and kindly follow up and not sort of push. Otherwise, people are going to balk at it. It's like, oh my God, now there are 10 more things that I have to take care of. So just upstream, we should think about that and leverage these things. We have, and then obviously choose wisely. We mentioned that this test should not lead to more tests. So a lot of times comes up, oh, I don't want to do a calcium scan because it'll be incidental finding. Yeah, but someone's going to die of a heart attack. What about that? So we just have to sort of think of this sort of approach. And so I'm at time, so I'll stop there. Thank you very much.